Hello, everyone. My name is Deborah Stafford, and I am a patient advocate. I was diagnosed with breast cancer, stage 2, um, hormone positive breast cancer in 2014. Um, Shortly after finishing my treatment, I became a patient navigator at my local cancer centers, and then within a year, dove deeply into research advocacy. And I am here today to tell you my perspective on science. What have you done for me lately? I as Since I have been serving as a research advocate, especially for the DoD Breast Cancer Research Program, I am in awe of these amazing human beings with incredible minds who dedicate their lives, their education, their hard work to developing a cure for our disease, make our lives easier um, as we live with our disease. And I'd like to share some of that with you today. Next. And this is just a little montage of the things that I do, some of the education that I've had, the American Association for Cancer Research Scientist Survivor Program, the National Breast Cancer Coalition's project lead, as well as the Alamo Breast Cancer Foundation's Alamo Scholar Program at the San Antonio Breast Cancer Symposium. I now serve as a scientific advisory committee member for the Dr. Susan Love Foundation, and I started my own nonprofit, Roar Care, which is reclaiming ourselves after recovery. This can be recovery from the news that we have cancer, the news that we have metastatic cancer from particular treatments. And our goal is to help cancer thrivers and survivors build a life that they love in their new normal, whatever that is. Next. All right. The first thing that I'm going to share with you today is a study that was done by the National Breast Cancer Coalition, or a review of metastatic breast cancer research funding in the fiscal year 2016. So, 4 advocates decided that they were going to look at what percentage of federal funding, the biggest source of funding of breast cancer, is really going to metastatic breast cancer research. Next. So these 4 project lead educated and experienced research advocates, they all 4 of them had done um, significant research advocacy at the national level. So we have, from left to right, Michelle Atlin, Judy Perkins, who you will be hearing from during the course of this month, Tracy Leduc, and Andrea Hutton. So they together reviewed 1,693 NIH-funded breast cancer research projects and 87 Department of Defense congressionally directed medical research program, breast cancer research program funded projects. Next. All right, so how did they do this? How did they determine which of these research projects were actually uh, significant to metastatic breast cancer? So one of the things they looked at was keywords. The keywords they looked for were metastasis, cancer progression and metastasis, metastatic breast cancer patients, tissues from metastatic breast cancer patients, and animal models of metastasis. So, and it's clear from this that we are getting direct understanding of metastatic tumor tissue, or what is happening in a metastatic patient. But in addition to that, there are basic science projects that are also related to metastatic disease. And sometimes these aren't as obvious if you're not experienced that they are actually related to metastasis or progression of cancer. Some of these key words are epithelial mesenchymal transition, cancer stem cells, circulating tumor cells, and invadopodia. So these are additional words that you might miss when you're looking for what research is truly benefiting a metastatic breast cancer patient. Additional areas of focus that they scrutinized, they also looked for projects that dealt with these uh, which are recurrence and resistance. So, treatment resistance includes chemo resistance, hormone therapy resistance, HER2 resistance, and targeted therapy resistance. And these were scrutinized more carefully because they may or may not have had a direct relationship to metastatic breast cancer. Next. All right. So, what did these four dedicated patient and research advocates find out? Okay. First of all, let's give the big number at the end, which is that approximately 20% of all federal funding on breast cancer research is specifically for metastatic breast cancer research or impacts metastatic breast cancer. um, and the two major sources of federal funding for breast cancer include the Department of Defense congressionally directed medical research program, and specifically within that, the breast cancer research program. Um, the total budget for the fiscal year 2016 was $97.7 million. The total spent on metastatic breast cancer related research was $52.8 million. The percentage of funding spent on metastatic breast cancer in this case was 57.6%. Now, there are a few things that you need to know about the Department of Defense congressionally directed medical research program. This program was initiated in 1991 by breast cancer patient advocates. This included scientists and patient advocates who knew that we needed to do something more. So they came together, they formed the National Breast Cancer Coalition, and one of the founding members of this coalition is Dr. Susan Love, which will become significant later. And they asked all the researchers they knew, how much money do we need to cure breast cancer? The answer they got was $330 million. Well, they went to Congress, they asked for the money, they got the money, and initiated this very new funding source for research. And this funding source is for high risk, high impact research. So we want to really fund those projects that maybe don't have as much evidence behind them, and really take these new ideas and see where they can lead us and see if we can make progress on breast cancer. The other thing that the National Breast Cancer Coalition asked for when they created this program was that advocates be at the table. And so the grant review process through the Department of Defense, CDMRP, is always has advocates at the table as equal members. I am one of these advocates. I do written evaluations of the impact of the research proposals that I read. I sit on the panel as an equal member with the researchers, the scientists, and clinicians who are at the table. And these are really important factors um, in how that money gets allocated. So I think that is an important thing to consider, advocates being at the table, and this focus on high risk, high reward research. Next, the other major and actually bigger source of federal funding for breast cancer research is the National Institutes of Health Breast Cancer Research Portfolio. So their total budget in the fiscal year 2016 was $656 million. The total spent on metastatic breast cancer related projects was 96.4 million for a percentage of the annual budget of 14.7% spent on metastatic breast cancer research. So, as we can see, with um, the total federal funding for breast cancer research in the fiscal year 2016, about 20% of it was spent on research that directly impacts metastatic breast cancer. Next. And I provided this slide for you. This is actually the poster that those four National Breast Cancer Coalition advocates presented at the San Antonio Breast Cancer Symposium. So I just wanted that for your reference. Next. All right. So now that we know how much money is being spent on metastatic breast cancer research, let's see what the scientists have managed to accomplish in helping us to have a better life, maybe even potentially finding a cure. Probably the most likely strategy for finding a cure to breast cancer, to actually have a patient who has is free of disease, declared free of disease, is adoptive cell therapies. Adoptive cell therapies were developed by Steven Rosenberg. He is an MD, PhD at the National Institutes of Health, the National Cancer Institute, and he is considered the father of immunotherapy. So, about 100 years after the first physician noticed what we later know was an immunotherapy, which was Coley back in 1891. 100 years later, Steven Rosenberg developed the drug that became, or the therapy that became the first FDA approved immunotherapy in the United States. And this was interleukin 2. It was FDA approved in 1991. It is still used today. It is mostly used in kidney cancers today. And one of the advocates that I have served with, Howard Brown, he was cured of his lymphoma through Dr. Rosenberg's IL-2 therapy. He was in that clinical trial back in the day. At his lab is Stephanie Goff. She is senior staff and is responsible for the adoptive cell care of adoptive cell therapy patients. And just so that we know what adoptive cell therapies are, these therapies, scientists take your own immune cells out, educate them to fight cancer or select ones they think are most likely to fight your individual cancer, and then they reintroduce them to your body. Now, the picture in the center, Judy Perkins, and she is one of those advocates, those NBCC advocates who did the poster on metastatic breast cancer funding, federal funding for metastatic breast cancer research. And she received tumor infiltrating lymphocyte adoptive cell therapy. So what this is, and we'll talk about this a little more later, we will often hear about the tumor microenvironment and whether immune cells are able to get into that tumor microenvironment and fight our cancer. So in many cases, our tumor microenvironment will block those immune cells from getting in. So those tumor infiltrating lymphocytes that were in Judy Perkins' body, they pulled them out. They looked at the targets on her cancer cells, and they chose those tumor infiltrating lymphocytes, her immune cells that had that were cued to respond to those specific 4 biomarkers. They grew those, multiplied them, and then they put those lymphocytes, her immune cells of the type that could fight her cancer with those 4 biomarkers back into her body. As a result of this treatment, she is the first patient with metastatic breast cancer ever to be declared disease free, cancer free. Um, the lab has tried to reproduce these results and as yet has been unsuccessful. But at least we know there is a possibility. Perhaps we can understand what it is about Judy herself, her anatomy and physiology, her cancer that made this therapy work in her case. We don't know what the scientists don't know where we need to go um, to reproduce this and make this work at a broader level. But even one case where we achieved that disease free status is exciting for the future potential that metastatic breast cancer research has. Next. All right. Now we're going to go on to repurposing already FDA approved drugs to treat metastatic breast cancer. Um, Linda Vadot, who will be speaking on October 3rd, that's Saturday, took a already FDA approved drug for a completely different disease and repurposed it to treat breast cancer. Um, the advantages to this is we already know the toxicities of this drug. It's already FDA approved, which means we're going to be able to get it to the patients who need it more quickly. For those of you who attended Dr. Salia's talk earlier, there still will be time from this idea to getting this medication to the patients, but it'll be much less than it would if this drug were not already FDA approved, which means there were safety studies done already. Now, it turns out that copper is necessary for many of the things in the tumor microenvironment that cancer needs to spread and thrive. So some of these are angiogenesis. So we know that no tumor, no cancer tumor can grow beyond 1.5 centimeters without creating a new blood supply to feed it. Cancer is ravenous. It's like a guy at a hot dog eating contest who's just stuffing his face, fist by fist. Our normal cells, they sit politely at the table, they cut their food, they take one bite at a time, maybe they have conversation in between. So always remember in terms of cancer metabolism that cancer cells are greedy, hungry little double stuffing your face metabolizers, eaters. So lowering copper levels to about 15 to 20% of the baseline. So if you just went in, had a blood test, had your copper levels tested, going down to about 15 to 20% of that still allows your cells to function normally, but it prevents angiogenesis. And it prevents some of these other things that I will go into as well. So, um, so this is exciting that we could have a tool that is already FDA approved, which means it's also inexpensive. It's probably off patent by now, and could have a huge impact and be delivered to patients more quickly. So some of the other places where copper is important in the tumor microenvironment are some of the enzymes that condition the pre-metastatic niche. These are things that cause chemical reactions, allow things to happen that make that space in the body more friendly to metastatic colonization. Now, and then the last place where copper is important is the collagen scaffolding that is necessary as a landing pad for tumors that are spreading. So in all of these ways, reducing copper levels uh, will help prevent progression and recurrence of triple negative breast cancer specifically and treat metastatic breast cancer. Now, the reason that we're talking about triple negative breast cancer specifically is that triple negative breast cancer does not have any preventative that one can take long term. For estrogen positive cancers, we have tamoxifen, we have the aromatase inhibitors, we have options to prevent that progression and recurrence. But for HER2 positive cancers, we have Herceptin that you take long term to prevent that recurrence. But for triple negative breast cancer, we have not had um, any drug that could be used after the cancer is removed by surgery and adjuvant therapies that would then hopefully prevent progression or recurrence. So it is very exciting that we have this tumor microenvironment disrupting drug that we can potentially use to prevent the progression and recurrence of triple negative breast cancer and to even treat triple negative breast cancer. Next. All right, let's look at some game changing women scientists who are not only doing new and innovative research, but are changing how research is done. So the three superheroes of this story are Patricia Stieg at the again Center for Cancer Research at the National Cancer Institute. She is the deputy chief of the Women's Malignancies Branch. Next, we have Dr. Susan Love, who we've mentioned before. She was one of the founding members of the National Breast Cancer Coalition. She is the Chief Visionary Officer of the Dr. Susan Love Foundation for Breast Cancer Research, and which also includes the Love Research Army, which we will discuss later. The third hard hitter is Laura Esserman. She is the director of the Breast Care Center at UCSF and the founding principal investigator at Athena Breast Health Network. All three of these women are mavericks and game changers and are changing the playing field, which means that we have people fighting for us that are changing the playing field to make it more favorable for breast cancer patients and metastatic breast cancer patients. Next. All right, let's start with Patricia Stieg, and she will be speaking on October 27th, so don't miss her talk. She is redefining endpoints for metastatic breast cancer clinical trials. So, the way clinical trials for cancer work is that the typical endpoint has to show that the tumors actually shrank. Well, in the case of metastatic breast cancer, most therapeutic interventions are unlikely to exist to reduce existing metastatic lesions. Those metastatic tumors are unlikely to shrink. So, when you test a drug for metastatic breast cancer, and it is only testing for whether those metastatic tumors are shrinking, these drugs are going to fail and they're never going to get to the patient. So, new endpoints needed to be developed to demonstrate prevention of metastasis. So we needed a new endpoint that shows whether metastasis is happening at a slower rate or whether it's not happening at all. These trials take more time and money than those trials that are looking for shrinking of the tumor, which is one of the challenges in moving forward with this. But Patricia Stieg is a champion for all of us and is um, looking to what are the types of metastasis prevention. So she has identified two types. Prevention of a first metastasis. So you've done your early stage cancer treatment and you have not had any evidence of metastasis. So this first endpoint would be looking for um, patients who are getting these therapeutic agents who are not getting a first metastasis when other patients who are not being treated with that agent are. The second level of prevention of metastasis would be prevention of additional metastases. So, this is somebody who already has metastatic breast cancer, and we are the endpoint would be with this therapeutic agent, are new metastatic tumors not forming that would be forming in the patients who were not receiving the intervention. So this is again exciting. If metastatic breast cancer patients are going to benefit from therapies that may prevent metastasis, either first metastasis or secondary metastasis, this could be game changing. Next. All right. And now Dr. Susan Love, again, the founder of the National Breast Cancer Coalition. And she created the Love Research Army. And her philosophy is we are not mice, and breast cancer needs to be studied in human subjects. Um, there are limitations that come from using mice to study breast cancer, one of which is that mice do not naturally get breast cancer. Another issue is human beings are a very diverse population. We, we have different genes. In certain communities, there are, like for instance, in Americans of African heritage, there is a unique translocation BRCA mutation that is not found in other populations. Um, so we know that human beings are diverse. We're different backgrounds. We live in different places, and mice are, not genetically, lab mice are not genetically diverse. They're living in sterile conditions. They're not having the impact on epigenetics or the diversity of genetics that human beings have. If we're going to represent the full diversity of humans that are impacted by breast cancer, then we need to study it in humans with their full diversity. So Dr. Love recruits humans to participate in breast cancer studies. And I encourage you to check out the Dr. Susan Love Foundation and the Love Research Army. Sign up, start signing up for various studies that she puts out there. Um, Dr. Susan Love also has always been committed to preventing collateral damage, to studying collateral damage. She thinks collateral damage matters. That means your quality of life matters. Toxicities to your liver and kidneys and cognitive function and all heart, all of these things that can come from breast cancer treatment are things that she studies, and those have a huge impact for those with metastatic disease who, may have to go from treatment to treatment, and the brutality of some of those treatments on patients' bodies. And the more we can understand about collateral damage and how to prevent collateral damage, the the better quality of life that we can have, because quantity of life is not enough. It also has to be quality of life. And if we are going to be healthy enough for future treatments that may come up that might be game changing, we also have to minimize collateral damage, because if our livers or kidneys or heart are not healthy enough, we may not qualify for a trial with a new drug. So this is, again, or a new therapy, a really important thing to consider in breast cancer research. Dr. Susan Love's new project, her passion of the moment is mapping the anatomy of the human breast. We know so much about every other part of the human body. We know so little about the human breast. We do not know how many holes are in the nipple. We don't know much about those ducts and lobules where our cancer occurs. This becomes very significant for patients with lobular carcinomas. We are not good at visualizing those, at screening for those. And so most patients are diagnosed de novo with advanced disease. Understanding the human breast better could change that. So I am very excited about this. I am hoping that this will give us so much more insight that will allow us to develop better screenings and better therapies for breast cancer and metastatic breast cancer. Next. All right. And now, Dr. Laura Esserman. Dr. Laura Esserman, like Dr. Stieg, is changing how research is done. So she was frustrated by the slowness of time that it takes to get therapies to patients. When we're in a clinical trial that, say, has 2 or 3 arms where you're receiving standard of care, or you're receiving 1 or 2 new potential therapeutic agents, we're in that study on that therapy for the duration of the study, unless we progress and we fall off, or unless we choose not to continue with the study. So that means a lot of time dedicated to a therapy that may or may not be effective for our particular case. So Dr. Esserman looked at the tech industry for how they innovate, and she developed the adaptive clinical trial model. The exciting thing about the adaptive clinical trial model is that it gets the right drug to the right patient at the right time, which we hope is now, right? So, how this works is this clinical trial model has multiple therapeutic agents, and a patient is started on an agent, and if that agent is beneficial, then they continue on that agent. If it is not, they are shifted to a new agent. And ultimately, by the end of the trial, if any of the therapeutic interventions being studied, if any of these drugs being studied is effective for that patient's cancer, they are going to end up on that drug. Um, After the first iteration of I SPY 1.0, they started having enough data to figure out which therapies were most likely to be beneficial in which cancers, and which also had the lowest toxicity. So then the process was further streamlined to patients being given the intervention that was the most likely to be effective in their cancer, and um, the lowest toxicity. And then you progress through um, in a more flow chart kind of way. Now, this means that, one, you are not spending an entire study on a therapy that isn't benefiting you with your specific cancer. So time is worth more than anything else when we have had a cancer diagnosis. So giving us that time where we can be on a therapeutic agent that works is invaluable. And second, this new adaptive clinical trial model has fast tracked FDA approval of therapeutic interventions for breast cancer. When you are making sure that the the drug that somebody is getting going is benefiting them as they continue on in the trial, then the results that you get are going to be more positive for that drug, and you're going to identify who should be getting that drug. So this this trial is one that led to, in I Spy 1.0, 8 drugs being fast tracked to FDA approval, which is mind blowing and game changing. Um, and I did see a question about whether this was for all stages or metastatic breast cancer. Now, this is something that is being done with early stage cancers, but has an impact on preventing metastasis and also in, um, again, making sure for those patients who might have the potential for metastasis that they're getting a successful intervention early on. And the more that we are able to figure out which adjuvant therapies are effective at in which cancers, we will hopefully be able to prevent those metastases from ever occurring. And Dr. Esterman also is the founding principal investigator of the Wisdom study. Now, the Wisdom study is a screening study. So, how does that relate to metastatic breast cancer? Well, most of the patients that I know who have children or grandchildren or nieces or nephews, they want their descendants, their beloved children, grandchildren, and nieces and nephews to have a better chance than we have had. And the Wisdom study is a personalized screening study. So it is going to look at each participant's uh, personal and family history of breast cancer, their genetics, the environment they live in, all of the factors that could influence their potential to get breast cancer, and takes those into consideration when developing screening. Starting, um, you know, 30 years ago, when we started widespread population-wide, increasing population-wide um, screening mammograms starting at age 40 every year, um, we have found that that has not reduced death by breast cancer, which is death by metastatic breast cancer. So, um, this general screening doesn't seem to be doing what we wanted it to do. Now, death rates from breast cancer have gone down, but they've gone down because we have superior treatments, not because the screening is better. So one thing that we know is that we need better screening, and so I am excited for future generations, especially those who are in families with genetic predispositions to breast cancer, family histories, that they will have a better chance than we have. And next, and Julia, I will answer your question as soon as I'm done here. All right, let me go in here. All right. So, and next, Darren. All right. So, um, if there are any questions, You can post those in the chat. All right. Thank you, everybody, for your participation, and I look forward to seeing you elsewhere in our conference. All right. Thank you.